It is my great pleasure to introduce our speaker today, Dr. Ralph Sacco. He's the chairman of neurology, Allenberg Family Chair in Neurological Disorders, Miller Professor of Neurology, Public Health Sciences, Human Genetics, and Neurosurgery. He's an executive director of the Evelyn McKnight Brain Institute at the Miller School of Medicine, University of Miami. He's also chief of the neurology service at Jackson Memorial Hospital. Dr. Sacco is a graduate of Cornell University in bioelectrical engineering. He graduated magna cum laude from Boston University School of Medicine and completed his neurology residency and postdoc training in stroke and epidemiology at Columbia Presbyterian. Dr. Sacco is known for his contribution in the areas of stroke prevention, treatment, epidemiology, and risk factors. His research has also addressed healthcare disparities. He's the founding PI of the NINDS-funded Northern Manhattan Study, the Florida-Puerto Rico collaboration to reduce stroke disparities, and the Family Study of Stroke Risk and Carotid Atherosclerosis, as well as co-investigator for multiple other NIH grants and international stroke trials. Dr. Sacco is the current editor-in-chief of the Stroke Journal. He's on the board of directors of the World Stroke Organization. Dr. Sacco serves as the immediate past president of the American Academy of Neurology. He was also the first neurologist to serve as the president of the American Heart Association. Please join me in welcoming Dr. Ralph Sacco.
Good morning. Thank you for that kind introduction. Sorry I can't be there in person with all of you on this Grand Rounds Day, but at least we're there virtually. So let me just see if I can bring up my slides. Are you seeing that? And let me move to slide mode. Give me a nod if you can see that.
Yes, we see. Thank you.
Great. So happy to be here and talk a little bit about an important topic that I think you all face as well regarding healthcare disparities. And the topic is how do we take data and then really transform them into actions? As an epidemiologist, and it's all a lot about observations, but over time, there has to be some way to take those observations and transform them into actions. My disclosures are listed there. Our Florida Stroke Registry is funded by the Florida Department of Health, and I have NIH funding for the work I do in Northern Manhattan Study and other grants, and then the American Heart Association as editor-in-chief. So let's see now, why is it not moving? Okay, so what I would like to cover this morning is, one, just to briefly define health disparities, observations on race and ethnic stroke disparities that we learned over the years from the Northern Manhattan Study, that also give us some perspective in what can be done to reduce those disparities, and then talk about the development of our Florida-Puerto Rico collaboration to reduce stroke disparities, which grew out of an NIH grant and then now is formulated by the Department of Health and the Florida Stroke Registry, and talk specifically about how measurement itself and following evidence-based guidelines will be a way to approach and reduce stroke disparities, and then the way we have tried to change some Florida policy to raise the bar for stroke care across all race and ethnic subgroups. So first, what is a health disparity? A health disparity is really just a measurement, a difference, inequality, usually in terms of a measurement like lack of equality for opportunity, for treatment or status. Often we characterize it in terms of rates, mortality rate or a death rate from the CDC, percents or means. It's really the quantity that separates a group from a reference point or a particular measure of health. The focus on disparities is usually first to call attention that there are differences. So for example, sex differences between men and women, race differences or ethnicity differences, Hispanic and non-Hispanic people. Regional differences can be looked at between regions, urban and rural differences, or even state or regions of the country. So it's a way to group things and then look quantitatively to see whether there is a difference in a measurement, absolute or relative terms. Often just calling attention to the measurement doesn't yet disclose the cause, but it begins to then focus us on an area of public health need for more research to figure out what is the cause of the disparity, and then obviously what are the interventions one can do to reduce that disparity. So here's a great example. US Census constantly tracks death rates. These are age-adjusted death rates shown for heart disease and stroke in the blue. You can see heart disease at the time from 2014 to 2016 still exceeds that of stroke. And this is just mortality, remember, age-adjusted death rate, which is not always the best measure for stroke. Disability would be a better measure and could still show disparities. And you can see there are some disparities, and the majority of the disparities have been noted in African Americans, where you can see a age-adjusted death rate of 101 versus 72 versus 70 for white, 62 for Hispanic. Hispanics are much more heterogeneous. And if you subgroup them into certain subgroups, including Dominicans, like we've looked at in Northern Manhattan, versus Mexican Americans that may be more prevalent in California and in Texas, there could be differences. But you can see that's just an example of a disparity in terms of a rate. The reason why it is important for us to be focusing on race and ethnic disparities, as anyone knows, when you look at the changing population in where you are in your downstate, in Manhattan, in Florida, for example, we're now about 88% non-white in the city of Miami. And the projections are that we'll live in a much more heterogeneous population when you project to the future. You can see with the growing numbers, particularly Hispanics, that will reach 30% of the population, at least projected by 2050, and African Americans will be 15% of our population. So it is important for us to be ready to care for and deal with the issues regarding stroke and other healthcare disparities for this group. So we started way back when I was at Columbia, a study to look at some of the differences in Northern Manhattan. And the nice thing is in our population laboratory, we could actually measure, we had the denominator, at least from census tract data for white, African American, and Hispanic population subjects living in the region. And we really had mainly one big hospital that had two sites to capture the numerator, numbers of hospitalized strokes. But we also worked at the time when we set up for incidence studies, a collaboration with other hospitals in the area. You can see the population in Northern Manhattan back then was about 15% white, 20% African American, and about 63% Hispanic. So we set up the study at Columbia, and then when I moved to the University of Miami in 2007, the study has continued. Our focus has changed over the years from stroke to other important neurological conditions like dementia and vascular cognitive impairment, and we have a great team of people continuing to follow the cohort in Northern Manhattan. The study has really evolved, and when you look at some of our publications, originally we were an incidence study. We were calculating the number of people with stroke, different subtypes across white, African American, or Hispanic. We then were evolved into a case control study where we were looking at differences in risk factors in the subgroups. Then using our controls, we continued to expand that collection and moved really into the gold standard Framingham-like design of a Northern Manhattan study, a prospective cohort study. And that is really the focus of most of our work now, in that prospective cohort of 3,298 people followed over time. We added a family study specifically to look at genetics, and that those families were Hispanics, particularly Dominicans, almost 100 Dominican families with large numbers of people in the family that we enrolled, mainly to begin to look at risk determinants, genetic determinants of carotid disease and other complex disorders that will increase the risk of stroke or vascular disease. And then we also focused on an MRI cohort with neuropsych assessment. And the neuropsych cohort is the group that we have been mostly publishing on now. It's just looking at vascular cognitive impairment and dementia. And that group has been followed with 3 neuropsychological assessments and a baseline MRI. Most of what I'm going to focus on today will be, at least some of it, from mainly the stroke regarding study. So this was one of our earliest publications that looked at the incidence in Northern Manhattan from the incidence study of whites living in the population in Northern Manhattan, Hispanic, mainly, mostly Caribbean Hispanic and the majority Dominican, and then African Americans. And this is age-adjusted numbers and sex-specific. First thing you see is that men have a greater incidence of stroke, regardless of the race ethnic group, than women. And this is age adjusted, though women live longer at any point in time. So the number of women with stroke in terms of prevalence is greater. And the second thing, you see that the mortality that we have noted from the CDC numbers is likely driven by incidence. And this shows the greater incidence of stroke in our African-American subjects in Northern Manhattan compared to white Americans living in Northern Manhattan. And then this is one of the first numbers looking at Hispanic, and mainly Hispanics were Dominicans, which was intermediate but higher than the whites living in Northern Manhattan over the age of 20. Now, we couldn't tease apart the reasons because this was an incidence study. You don't have all the underlying data on the population at risk to tease apart all the different reasons. We were able to show important differences in stroke subtype. For intracerebral hemorrhage, almost a threefold greater risk for Black versus white for incidence of intracerebral hemorrhage. We also found differences for large artery disease, particularly intracranial athero. Intracranial athero was fivefold greater in terms of incidence for Hispanic subjects versus white, and a good 5.9-fold for African Americans versus white. Extracranial was also a little greater, 3.2 and almost twofold. So all different types of stroke were greater, but there was a preponderance of intracranial athero in our African American and Hispanic group. And then for lacunar disease, small vessel disease, threefold greater for Black and twofold greater for Hispanic. But interestingly enough, the numbers weren't as different for cardiac embolism. And that will be another theme. You'll see that there is sometimes a difference in the preponderance of vascular risk factors. Atrial fibrillation was more prevalent and more important, at least in terms of as a cause of stroke for cardiac embolism in the whites. So yes, we still had a greater risk or incidence for Black versus white and Hispanic versus white subjects, but you can see these numbers weren't as great as the differences for intracranial athero, for small vessel disease, and even for intracerebral hemorrhage. So a hint that some of the differences, particularly in stroke subtypes, may be driven by differences in risk factors. So the prospective cohort, as I mentioned, we collected the controls. So these were stroke-free subjects from 93 to 98. Mean age was 69. And you can see, again, they reflected the underlying population in terms of the makeup of the race ethnic group. We added a lot of different variables over time, including some carotid ultrasounds, the brain MRI, and then we continued to follow this group, particularly for stroke, MI, and death in a prospective cohort, but also for MCI and dementia. I won't be showing any of the MCI and dementia data today. Our focus or our model was to look at obviously risk factors, and particularly look at basic and traditional as well as novel risk factors as they relate to the risk of stroke. Also, the pathways through subclinical vascular disease, i.e. carotid disease and cardiac disease. We had cardiac echo findings, LV mass, LA size, and then particularly to look at these stratified by white, African American, and Hispanic group, looking for interactions. Are different risk factors either more prevalent or are they differentially greater in some groups more than the others to explain the outcomes? We have done the same now with subclinical brain disease as characterized by white matter hyperintensities, silent strokes, cerebral microbleeds, perivascular spaces. And in the same approach looking at for stroke, we're using that for cognitive decline, MCI, and dementia. Being able to really test, are these risk factors related to the intermediate phenotypes, i.e. for subclinical brain disease or vascular disease, and then how do they relate to the final clinical phenotype, cognitive decline, MCI, and dementia, but particularly for stroke. So now we're able to look at the incidence in that cohort. And this is new data that was published last year and shown at the last in-person stroke meeting, where we have then really corroborated the incidence findings in the population-based incidence study with our prospective cohort. So looking at that 3298 subjects, followed them up, an average follow-up of almost 10 or more years now, 14 years, I'm sorry. And you can see the crude incidence was 9 per 1,000 person years for white, 13 per 1,000 person years for African-American, and 10 per 1,000 person years for Hispanic. And there are differences across the age groups. In other studies, it's been shown that some of the race ethnic disparities are greater for younger individuals. And you'll see that when I show you data from the Florida Stroke Registry. The age at which Hispanic and African-Americans may have their stroke is often quite younger. So in, for example, Cincinnati, and in the REGARD study, they were able to show bigger race ethnic disparities in younger group. Our group, however, showed race ethnic disparities even in those over age 70. And particularly, we found them in older women. You can see for 70 plus women, a 1.77 for Hispanic versus white, incidence difference in the prospective cohort, 1.76 for Black versus white, in our 70 plus women. So big difference for women in our cohort. We had more women. Women live longer, as I mentioned, so we may be able to pick up some of these disparities at older age groups. So we were able to show again in the prospective cohort now, where data is still a little bit limited because of the numbers, but a trend that shows these differences in incidence. Over the years, we've also looked at a variety of risk factors. The traditional ones like hypertension and diabetes, behavioral ones, the protective effect of alcohol, the importance of physical activity, sleep, migraine, obesity, diet that's been broken out in terms of the Mediterranean pattern for diet being protective, salt or sodium consumption being deleterious, and fat, and even diet soda, increasing the risk of both diabetes as well as vascular conditions like stroke. Social factors, including social isolation and socioeconomic status, which you often control for and may be differential across the different race ethnic groups, metabolic syndrome, other risk factors, cardiac risk factors, working with our cardiologist colleagues, and not just the usual ones, but actually trying to measure like LV mass, left atrial burden, and even now, some of the data that went into the cardia study, the cardia trial that's out there in terms of P-wave terminal force came from data in the Northern Manhattan study. And then Mitch Elkin, my multiple PI, the co-PI of the study, has very much been focused on inflammation and infection, chronic infectious burden as a risk factor for various conditions like stroke, MI, vascular death. But when you still harken back, the main key traditional vascular risk factors that many large organizations have focused on, and we still don't do well enough in terms of control, are still probably the majority that actually predict the risk of stroke. So the AHA in 2010 kicked off a large campaign called Ideal Cardiovascular Health and Life Simple 7 key factors that they thought were the most important for defining ideal cardiovascular health. And those simple 7, including 4 behaviors and then 3 numbers: never smoking, a body mass index less than 25, physical activity, about 150 minutes of moderate or 75 minutes of vigorous physical activity each week, 4 to 5 key components of a healthy diet, cholesterol less than 200, blood pressure below 120/80, and fasting blood glucose less than 100. And each of those 3, for example, to be ideal, you had to have those numbers in control without even being on medications. If you're on medications, it was intermediate. And for diet, it got even more difficult. Fruits and vegetables of 4.5 cups per day, fish, 2 servings per week, fiber-rich whole grains, 3 servings per day, sodium less than 1,500 milligrams per day, which is even more stringent than the USDA guidelines, and then sugar-sweetened beverages less than 450 calories per week. So these were at least defined as ideal cardiovascular health. Whenever I poll an audience and try to ask how many people are in ideal cardiovascular health, I usually have a few hands go up. Right now in the United States, it's probably less than 1% that meet all 7 of these ideal cardiovascular health conditions. So we tried to look at this in Northern Manhattan. And in Northern Manhattan, when we applied that definition to the population, no one had all 7 ideal factors in our Northern Manhattan study. So we said, well, let's call 6, not too bad. And about 0.5% had 6. And then we went even down lower and tried to say, well, how many, if we said had 4 or more? And you can see it was 19% overall had 4 or more ideal. And there were race ethnic disparities. Our Hispanic had the worst ideal cardiovascular health at only 14% having 4 or more, 21% in the African American, and 29% in the white having 4 or more in the individual. So there was a difference in the prevalence of ideal cardiovascular health in the underlying population. And then when you look at that over time, and this is a very important slide, and I think it demonstrates an important concept. Shown in the red is the group that had the worst ideal cardiovascular health, only having 0 to 1 ideal numbers. And then shown in the green are those that have 5 to 6 ideal cardiovascular health. And this is then looking at prospective data over time in the incidence of stroke, MI, and vascular death. And you can see, obviously, the incidence is greater in those that are having the age-adjusted incidence with the worst ideal cardiovascular health. And you see this trend with a reducing incidence in the more ideal health. And what's even more important, you see this trend across all 3 race ethnic groups. And actually, when you even look at the comparison of those in ideal health, race ethnic disparities seem to go away a bit. If you have people in 5 to 6 ideal cardiovascular health conditions, 19.1 in white, 19.6 in African American, and 15.2 in Caribbean Hispanic. So I think the concept there is that if we could get people into ideal health, you do eliminate some of these disparities. However, there is some heterogeneity. This shows across each of the groups all of the individual conditions: smoking, body mass index, physical activity, diet, blood pressure, blood glucose, total cholesterol. Across each of them, there are differential impacts. Smoking, for example, looked worse in African Americans. Hypertension, particularly worse in African Americans and Hispanics, you can see in the red there. Diet, equally poor across all 3 race ethnic groups. All 3 of the groups were pretty bad when it came to getting into ideal diet conditions. Physical activity worse than our Hispanics. So this then indicates that even though ideal cardiovascular health is differential, that there may be culturally appropriate in certain places where we have to do more tailored interventions. For example, campaigns for physical activity, inactivity in Hispanics, maybe more smoking cessation in African Americans, and blood pressure control, particularly for African Americans and Hispanics. So over time, I think the Northern Manhattan study has told us that African American and Hispanic persons have a greater stroke mortality and incidence. And again, Hispanics, there's heterogeneity. I can't vouch for that in Mexican Americans and other Hispanic subgroups, but data from the Corpus Christi studies and other studies now have also confirmed across the different Hispanic subgroups. Differences in vascular risk factors likely contribute to these stroke disparities. If we can get people into ideal cardiovascular health, if you can follow evidence-based guidelines to control risk factors, you can eliminate some of the disparities. Doing that is not easy and harder in certain culturally less accessible groups. Improving ideal cardiovascular health could help reduce disparities, but it's just, how do you get there? Novel risk factors, and I haven't shown you much of that data, and some of the subclinical determinants can also help improve early risk detection. And the approach that we've used for some of these novel or intermediate phenotypes is, can they help us predict earlier? And then can we intervene earlier before it's too late, before one has a stroke? And obviously, we need to be thinking about innovative risk factor intervention and awareness campaigns that need to be culturally tailored if we're going to really reduce those stroke disparities. So that is data from Northern Manhattan. When we got down to Miami, we had an opportunity to work as part of what was called a SPRIP, Stroke Prevention Intervention Research Program. The NINDS was funding 4 different centers to begin to work on looking at stroke disparities. So we worked out a collaboration with the University of Puerto Rico, and that's when we created the Florida Puerto Rico collaboration to reduce stroke disparities. And our focus was much more on acute stroke. Just as we had looked at in Northern Manhattan, disparities on stroke incidence and prevention, we wanted to look at acute stroke care and identify if there were disparities for all the usual things that we do at a primary or comprehensive stroke center. We wanted to then focus on developing, disseminating, and demonstrating interventions to reduce any identified disparities. And all of this was based on a collaboration. So we worked with, obviously, NINDS funding, the University of Miami, working with the University of Puerto Rico. When we started, Puerto Rico was very much engaged with us. That was before the hurricanes caused troubles there. And then obviously with the American Heart Association, CMS, EMS, and others to create this large data network that I'll show you. So over time, so we had funding from the NINDS to create our registry, and the registry then brought people together in the Florida-Puerto Rico collaboration to share data, and I'll tell you a little bit about what we did and what some of the data looked like. Over time then, after having the NIH funding, and this was a non-refundable grant, it was a 5-year grant, we were able to convince the Florida Department of Health and the legislature to then mandate a Florida stroke registry in the state of Florida. Obviously, the state can't fund Puerto Rico, so unfortunately, we are now the Florida Stroke Registry and getting annual appropriations to continue to expand the number of hospitals engaged and to create products and resources that I'll show you to address disparities, particularly across race and ethnic group, but also across region and sex. So this is kind of the conceptual framework for the Florida Stroke Registry. One, you need data. You need measurements. You need quantitative data to come in. Most of our data comes in from hospital-based data in Get With the Guidelines. Get With the Guidelines Stroke, as you know, has a lot of great data in it regarding acute stroke, including defect-free care, use of TPA, and now moving into endovascular therapy and other kind of quality improvement metrics that one can measure. We also tried to bring in pre-hospital data, and this is MSTARS, which is an EMS data set. There is some data on EMS data in Get With the Guidelines, but it's usually inadequate and often under-collected. So we were bringing in and then matching through other data sources, through data interoperability groups with EMS data. And then the biggest thing is looking at post-hospital data, and that is not easy. We still, in Get With the Guidelines, don't have good follow-up data. So for now, we mainly brokered CMS data, which is then older patients, through Medicare eligible patients, to look at outcomes after hospitalization. And now recently, because we're under the Department of Health, we have ACA, the Agency for Healthcare Association in the state, has all the hospitalization data, and we're beginning to collect and then look at outcomes data post-stroke using this kind of data. And then looking at this, we could track and analyze, look at temporal trends, identify disparities, and apply the 3Ds, develop, demonstrate, and disseminate best practices. Most of our focus was on the healthcare system, i.e. many of the stroke care teams out there across the state. And this is that important Get With the Guidelines quality improvement loop. The goal is to measure, track, benchmark, and then change over time. And that's why you see these quality improvement loops constantly trying to show improvement over time. And obviously we were interested in improvement over time across different race and ethnic subgroups. And then we are beginning to look at other multi-level determinants of health, including the community, policy and payers, and then the individual. But most of what our focus was to focus on the healthcare system. So looking at this data, we bring the data in, working with IQVIA, and then do a lot of cleaning to create some important, what I call dashboards. So, and these are our products, the hospital-based dashboard, a regional dashboard, a state dashboard, and then obviously a lot of education and outreach interventions to develop interventions to identify what these dashboards show. I'll show you them. And then how we can use these dashboards over time to address disparities as well as address improvements in care. So Florida is a big state, as you know. We're the third largest state right now and have the greatest proportion of people over the age of 65 and quite a number of stroke centers. You can see they tend to congregate around the coast where a lot of the population lives. And so this is our map at the moment. We have about 129 participating stroke centers. And the goal is to get all stroke centers to be part of this. In the beginning, it was voluntary. We weren't forcing all centers to come aboard. Now with the Department of Health, there's a little bit more of a state legislation that does mandate, if you're a stroke center, to put your data in the registry. And so we'll be going up to about, excuse me, 165 centers soon. We have primary, we have comprehensive, thrombectomy capable, acute stroke ready, and then a few that don't have their certification yet. So all of these centers collect data, we get the data in, and then we work with them to interpret that data. So as you can imagine, data accumulates quickly, and once in, you can go back to 2010 and look at obviously temporal trends in data over time. So right now in our registry from 2010 to 2020, we have about 313,000 strokes in. 2020, we don't have all the data in, there's always a lag. You can see for 2019, about 40,000 cases in the registry. So looking at the registry data, and remember, these are all stroke patients, we see, just like we saw in Northern Manhattan, differences in some of the prevalence of risk factors. So this is a complicated slide. First, you can see in our non-white men, we have, non-Hispanic white men, they're older at time of stroke, 72, 63 for the African Americans with stroke, and then 69 for the Hispanics with stroke. We find a greater proportion of dyslipidemia and atrial fibrillation, that important factor I mentioned to you before that drove why cardiac embolism seems to be a little greater in whites compared to African American Hispanics, a little greater risk of atrial fibrillation. Hypertension, 72%. They were greatest in our African American and Hispanics. And smoking, also, like I showed you in Northern Manhattan, 21% in the Black men that had stroke were smoking. Also, prior stroke or TIA was a little greater. And then diabetes, much more frequent in the Hispanic group, where obesity seems to be more prevalent. If we look at among women, we see actually for women, the African American women were the youngest at stroke at 66. Both Hispanic and white women were a little older at 77. Dyslipidemia and atrial fibrillation come out again as most frequent in the white group. And then diabetes actually in our white women, Hispanic women and our African American women was also prevalent, as well as hypertension. So like in Northern Manhattan, you see, now these are all stroke cases, but the stroke patients do also seem to have these same trends in the prevalence of these differences in vascular risk factors. And I think it's the differences in the vascular risk factors that then contribute to the incidence of stroke, the types of stroke, the complications of stroke, and sometimes the outcomes. But what we really wanted to focus on with the Florida Stroke Registry brought us into looking at these acute stroke measures. You're a stroke center, so you know, at least for primary stroke centers, you focus on the get with the guidelines, key metrics for TPA utilization. And at the older days, it was IV TPA, arrive within 2, treat within 3.5. We've now changed that, arrive within 3.5, look at treat within 4.5, early antithrombotic use, and a variety of other metrics that evaluate acute stroke performance. And then an overall measure called defect-free care. We also were looking at lifestyle measures at the time of discharge, outcomes like in-hospital mortality, ambulatory status at discharge, a modified Rankin score at discharge, discharge disposition. But as I mentioned, we still don't have all the great data for 30 and 90-day outcomes because we don't have good data for follow-up. And that's a focus that I'll mention towards the end for the future. And then we began to focus on other treatment performance, door to CT time within 25 minutes, that TPA, which now is in our primary, arrive within 3.5, treat by 4.5, and door to needle time, first within 60, now within 45, and then soon it'll be even lower. And the goal was to look at these acute stroke performance metrics and then compare them. White, African American, and Hispanics with stroke, as well as men, women, and other regional comparisons. So over the years now with the registry, we have published on a number of differences, and often we did find some race ethnic disparities early on, but I'll show what they look like over time. For defect-free care, we found sex disparities between men and women achieving less ideal acute stroke performance than men. We've also looked at race-ethnic disparities and compared some of the hospitals that weren't in our registry versus those that were. And the ones in the registry actually performed better in terms of race-ethnic disparities, door-to-needle times, minor stroke and TPA use, and continued need for stroke education awareness. And I'll mention that briefly about still activating 911 seems to be a very important difference in our groups. So this is one of our first publications where we did find some race-ethnic disparities, but it's an important concept to look at. So because you have time, you can see the longer you're part of a quality improvement program over time, the better and the least the amount of disparities. Look in 2017, how across the 3 race-ethnic groups, there was no difference in defect-free care. Early on, there may have been some differences, but these differences disappear the longer you follow that evidence-based quality improvement loop. And this was seen for a variety of metrics. So you see overall, when we control for certain confounders, there was no difference in defect-free care for our African-American versus white and our Hispanic versus white. There were differences for Puerto Rico. And as I mentioned, Puerto Rico was engaged with us, but now since the funding is only coming from the Florida Department of Health, we no longer have Puerto Rico with us. But there were early on some differences there where there's only one really certified stroke center. Look at disparities for 3.5, come in within 3.5, receive TPA by 4.5. Again, maybe some differences over time and then begin to eliminate. There's a hint, you see the confidence interval still includes 1 with African Americans compared to whites still getting that TPA utilization, even in those that are eligible, not as well treated, but it wasn't significant, but a hint that there's still a little bit of a difference. That keeps teetering a little bit where African-American versus white group still isn't getting TPA utilization as much as, say, the other groups. When we look at race, ethnic, and sex disparities, we also had some differences in door-to-needle time, but again, these differences vanished over time, where we now have no difference for door-to-needle time in 60 minutes, the longer you're part of the evidence-based improvement program. So when you can track and measure and benchmark and then provide resources to improve care over time, you can begin to eliminate disparities. And the same thing now with door to CT time, we still see a slight, again, just like you saw in TPA within 3.5 to 4.5, slight, there's a 0.86 less numbers of getting the CT within 25 minutes for those arriving within 24 hours. No difference in our Hispanic versus white, maybe a slight difference, but not significant for African Americans. And then for endovascular treatment, which has been the focus more recently, particularly in our comprehensive stroke centers, you can see first, look at the rise in endovascular therapy over time in 2010, the proportions that we're getting it. And then obviously when all the new evidence-based guidelines came out with all the new studies, we've seen a remarkable increase. And this is the total number getting endovascular treatment among those, I think, arriving within, I think it's 24 hours. You can see almost 10% for Hispanics, and then slight differences. And we do find that our Black versus white differences are less likely to get EVT. And this is after controlling for all the different confounders and getting in time. You have to be eligible, so you're still eligible within the denominator, but there is a little less EVT utilization that is significant right now in African American versus white, no difference for Hispanic versus white in Florida. So more recently, this looks at disparities in the delivery of endovascular therapy. So one, again, over time, an increase in the proportion that are getting EVT. 8% of all eligible to receive EVT are now getting it, of all of our strokes, of the ischemic strokes within 24 hours. And these were the predictors of EVT utilization. Women, a high NIH stroke scale, atrial fibrillation, and presenting at a high volume hospital were more likely to get the use of endovascular therapy. And those over age 80, there was a 13% less, and some of that may be reasonable, where we're making these kind of decisions with family about the use of endovascular therapy, even though some recent articles have shown even those over age 90 can still benefit, but there is still a important discussion that occurs with the family. And then here again is the African Americans. Our African American patients with stroke, at least a 12% lower risk or lower utilization of EVT that we're still trying to look at and determine reasons why. We then looked at disparities in hospital presentation. And again, there are differences in there. And this is comparing those that come in within 4.5 hours versus come in after 4.5 hours. In the group that comes in earlier, the group that comes in that were delayed, younger Black patients with stroke, higher NIH, some of our insured were actually in the delayed time window, admitted to academic hospitals, less likely to arrive by EMS, and less likely to receive reperfusion therapy, obviously, if you come in later. So there are some differences even in those who may come in early versus come in late, and this is for the TPA window. And obviously, these differences then translate into differences in outcome. If you come in late, you're less likely to be discharged home, and you're more likely to be getting discharged to rehab, which means you have greater disability. We've also now recently turned our attention to intracerebral hemorrhage. Most of our focus has been on ischemic stroke, but there are some important differences for intracerebral hemorrhage. And our intracerebral hemorrhages, again, in African Americans, they were young when they had their intracerebral hemorrhage, 60, more likely to have hypertension and diabetes, less likely to suffer in-hospital mortality, they are younger, and less likely to use early comfort measures, which were being used in other cases. So we are beginning to look at some of the differences by intracerebral hemorrhage, but this is still early and a new area of focus for the registry. So the goal of the registry, as I said, is first to kind of take this data and then really transform it into action. It's one thing to measure, but then it's another to say, what can we do to improve the quality of care? So we try to identify and address stroke care disparities, bring people's attention to where there is a disparity, show them how they compare to others, and then provide them with the best practices in stroke prevention, treatment, and rehabilitation. We've developed some interventions, and I'll show you briefly, and then obviously providing more education and sharing best practices with the group. Over time, as I mentioned to you, with the collaboration, we've been able to see across the whole registry big changes and improvements in some of these measures. Use of TPA, clot busting medicine, TPA now 3.5 to 4.5 is up to 90% utilization, treatment within 60, and then treatment within 45, 75% overall. And then EVT is coming up with now about 15% of ischemic strokes. So what are the interventions? What are the ways that we're trying to address and reduce disparities? One has been our disparities dashboard, and I'll show you what that's about. Regional dashboards, we're creating some dashboards and giving them to local stroke coalitions to then they can locally improve care. Annual meetings and educational opportunities and webinars and a listserv where people can interactively share best practices and talk to one another about what works in one hospital and what can work in another, and some interactive modules that we specifically developed for door-to-needle time. So these are the dashboards. The state-based dashboard now is available in open access. And this basically just shows all of those metrics for all of our hospitals and how they benchmark and compare to the nation. And we do pretty well. There are some differences that we try to highlight here and there, but overall, this shows the overall annual statewide dashboard. More importantly, we give each hospital an annual dashboard. And in that annual dashboard, they see all of their metrics, and they see them stratified by men and women and by white, African American, and Hispanic. And then they see their data compared to their region, if they're in the south part of Florida, the north part of Florida, and compared to the whole state. And then this is the first way that they can see their own data, where they're performing, and then where they may need to focus to improve care for one group more than the other. So these important hospital disparity dashboards have been really helpful to focus their attention on the acute stroke. performance. And that was mainly for the primary stroke centers. We now have pushed into the comprehensive stroke centers to look at not just IV TPA, but all the EVT measures. Percent EVT use among those arriving within 24 or within 6, but now we're going out to 24. Median door to groin time, median door to groin time among those not transferred, and then some outcome measures, including MRS 0 to 2 at discharge. And for the regional dashboards, we want to show the actual data for the overall group, and now we're beginning to show it across race, ethnic, and sex groups. So Florida, we begin to split up into certain regions. Obviously, Miami-Dade has a regional stroke coalition. Broward and Palm Beach were really the first out of the gate to take the data from us and work with EMS and other teams where they'll meet quarterly to digest, review, and figure out ways to improve the data. We have other regions developing now. West Central Florida was one big region, but they've broken down into other counties, Pinellas County, Hillsborough County, the Florida Suncoast Stroke Coalition. We're working on Orlando and Jacksonville to create these regional dashboards and giving them actually quarterly data where they can evaluate their data as a group and do something about it. So this gives you an idea of what some of the regional dashboards may look at. And you can see heterogeneity. These are unidentified hospitals. We don't name the hospital. These are the counties. And this is percent IV TPA overall for all the people coming in. I believe this is within 24 hours, forgetting about whether they're meet the eligibility or not. So you can see in hospital A, 15% utilization of TPA, 10% in hospital C, and the red hospitals are smaller hospitals, the blue hospitals are medium-sized hospitals, the green hospitals are the larger hospitals. And then you can see some heterogeneity in care overall across the different regions. Now, more specifically for EVT utilization, looking at these large hospitals, obviously EVT tends to be more in the comprehensive stroke centers. Here you have 2 hospitals coming in about 12%, one at 13%. And then differences in county. So it's a way to show the data in that individual region and give it to the EMS and the stroke leaders in that region to then follow it over time and look for improvement. And then we're beginning to dissect that across sex and race. So right now we do keep things de-identified. We provide the hospital with this data, and then the hospital goes out and gives the data to the EMS medical directors, and the EMS medical directors work with the hospitals and are able to piece it all together. I think in the future will likely be even more transparent, and there will be more hospital identification, but at the moment we still blind to the individual hospitals when we provide that data. We also have our registry website where we have a number of different resources available to the hospitals, the regional dashboards, the hospital-specific dashboards, many of the meetings, and we've created training videos. During COVID, we quickly pitched to COVID, and we're providing these very quick 10-minute updates for many of our hospitals on webinars so they can utilize the latest best practices with PPE and other material to improve the treatment of stroke during COVID. Here's the part where all the many different hospitals came together to create updates for different small videos. And then we also have now our quarterly newsletter. So it's all about sharing information. One hospital can learn from another. I often will see one hospital post, hey, have you had a Joint Commission virtual visit yet? And then provide some input to the other hospital of what it's like to go through a Joint Commission virtual visit for a reaccreditation for their primary or comprehensive stroke center. And this is another thing that we created in some other resources. We noted early that there were differences in door to needle time, and the differences were worse for African Americans. So we created this interactive module where it was sort of an education material that they could go in and they could teach for EMS and other people in the stroke team, figure out ways by questions and answering and avatars that were culturally appropriate to then have them interact with the resource and provide them with some important feedback of what correct ways and what ways to improve the door to needle time. For example, hanging TPA in the CT scan, calling ahead of time, different practices that have been already published that we know that works, but a different way to kind of improve education in this door-to-needle interactive module. We have our annual meetings and obviously had to go virtual in 2020, but these meetings again are all about sharing information. And actually now we're giving out awards. You know, people are always incentivized by awards, and we've given out awards for best improvement in stroke disparities, best improvement in tour-to-needle time, and other metrics across the different regions, bringing all the different hospitals together. We also have had an impact on policy, and that's important. When you get a large group together like this, you can influence the state policy and statutes. So the first was getting a Florida Stroke Registry mandated in the state statute. And this was the legislation in 2017 that then mandated that every stroke hospital has to be part of a stroke registry. Unfortunately, it didn't use appropriations each year. So each year we do have to advocate for the proper appropriations for us to run the registry. And then in 2019, we banded together, and now no longer can you just be a self-attested stroke center. That was what Florida had before, where somebody could self-attest that they were primary or thrombectomy or a comprehensive stroke center, and ACA would say, okay, yes, we'll certify you. Now you have to be part of a nationally certified stroke center like Joint Commission or some of the others. And that was, again, a change in policy that I think as a group we were able to affect change. So where are we going? What we're trying to do, obviously, as we move into the future is get more hospitals aboard. We want all 161 hospitals. We're increasing the number of regions so we can have all across the state, everybody having a region where they can work together. We're developing and disseminating more, obviously, stroke and COVID initiatives. We're working on a mapping utilization that will allow a publicly available mapping that where even the consumer can look at other stroke resources available. We've just applied for Paul Coverdale funding to be part of the CDC funding for stroke centers. We're increasing some work now, and I'm going to mention that a little bit in the last couple slides on how to look at transitions of care. We really feel that you can come into the hospital, everything goes great, and you get this defect-free care, but then you leave the hospital and you go into the community and there is not a great handoff. And so we're trying to work with community health workers and some other approaches to improve our transitions of care. The other thing, obviously, is looking at outcome data, because if we want to look at transitions of care, we want to have both outcome as well as EMS data. And we don't have a lot of good EMS data, but we are trying to get some in. And this was an approach to take already collected MSTARS data and then match it into the data set. And it's one way of doing it. And for example, we were able to show the timeline when one calls 911, how long it takes. And the biggest delay is still activating that 911 call. Once when people arrive, when 911 to arrival was only 10 minutes, on the scene was only 15 minutes, and the leaving the scene to destination was only 12 minutes. But look how long it still takes to activate 911 from the stroke onset time. And then some disparities. The biggest difference in the disparities was really driven by African Americans, where the time to activate 911 was the greatest. You can see in the red, on the scene was pretty good, and in the green, time on scene, and then in the purple, left scene to destination, all pretty good. So once you activate 911, there was no disparity in terms of getting to an acute stroke hospital, but getting the group to call 911, getting them to recognize those warning symptoms is still one of the biggest educational efforts that we need to do, and it's worse in African Americans. We have now turned our attention to follow-up, and follow-up is not easy. There is a tab in Get With The Guidelines to look at, say, lifestyle changes, stroke rehab, readmissions, wellness, but very few people get that outcome data collected. It's hard to collect outcome data. So we have tried to link with CMS, and we've done some publications, but that's only the Medicare eligible. It's only a small sample. It's the eldest group, and it's not the best in terms of looking at where all the disparities may be in the younger strokes. And then we've now recently been funded by NIMHD to look at a number of hospitals in transitions of care. And there we're collecting more information, including follow-up data, and trying to develop a transitions of care dashboard that will help us identify who will have a worse transitions of care, including in social determinants of health. And then most recently, with the state funding, we're going to get all the ACA data, which is all subsequent hospitalization data and other metrics data from all the state data. And we're going to match that in with the stroke registry. So we'll be able to have a little bit more of a total combined data use and bring it more together, including look at outcomes data. So overall, I'd conclude by saying we know that there are substantial race and ethnic stroke disparities. Northern Manhattan has shown it. Others have shown it. They exist. There are disparities out there, particularly for African Americans, but also for one of the rapid growing population groups, are Hispanic persons. Differences in risk factors likely contribute to these disparities. If we could, and that's a big, if we could improve ideal cardiovascular health in each of the groups, we really could reduce and eliminate some of these disparities. Participation in quality improvement programs, when we use evidence-based guidelines, whether it's primary prevention, like doing it for ideal cardiovascular health, or quality improvement programs at acute stroke, when you follow the quality improvement program and when you do evidence-based guideline improvement, you can reduce stroke disparities, even for acute stroke performance. There are still some, but it is less, but there are still some stroke disparities, particularly for African-American patients in acute stroke metrics. And I think we still have some ways to go in terms of door to CT time, utilization of EV endovascular therapy, and even TPA in the broader windows. Innovative educational programs, using hospital disparities and regional dashboards, looking at the data, digesting the data, and working collectively together to create tailored interventions are really what we need to do. We really need a lot of teamwork to really focus our attention on using the evidence that's out there to reduce these stroke disparities. In closing, I'd also say that it's great for me to be the one speaking today, but I'm thankful to the funders and the great teams that I've worked with, both at Columbia and now at the University of Miami for the Northern Manhattan study, and obviously for the Florida Stroke Registry. It's a great group and it's a collaboration. I'm thankful to Jose Romano, who's our director of our stroke program, is important for the educational metrics, Tatiana Rundek, who runs a lot of the data collection group, Carolina Gutierrez, Dr. Gutierrez, who's my right hand for the Florida Stroke Registry, the American Heart Association, and the Department of Health. You know, you can't do this kind of work in a vacuum. You have to work in teams if we're going to address and really reduce stroke disparities. Thank you very much, and I'll be happy to take any questions.
Thank you, Dr. Sacco, and we are open for questions now. I see there's one question in the chat from Dr. Wang.
Do you want to?
I can read it. So,
okay, find the chat. Wait a minute.
Did Florida Department of Health collect and monitor stroke center data as New York State and many other states, besides get with the guidelines? If
no. So Florida is not currently a Coverdale state. Right now, there are only, I think it's 9 Coverdale states. So it's not every state that has data that is benchmarked together. So Florida was not a Coverdale state. Recently, they've just opened up the applications. I know New York State probably went back in. They're going to have 13. So out of the 50 states, only 13 Coverdale states, which are CDC funded states to collect data, either on a Get With the Guidelines platform or some other platform. So obviously we've had the resources to do this. I hope we'll be competitive to be a Coverdale state and join the others out there, including New York State, with looking at this. In the new Coverdale program, they are focusing a lot more on the transitions of care and the outcomes, as well as some more work on primary stroke prevention that will be part of the new Coverdale programs, and we hope to be among them.
Hi, Ralph. Bill Litton here. It's good to see you've done so well since residency. But the question is about stratifying by economic aspects rather than just race. And I wonder if that's something you've looked at.
Yeah, great comment, Bill, and good to hear your voice. So in most of our analyses, we will control for socioeconomic status. And it's not easy. That data is not easy to come by. For Northern Manhattan, one of the best correlates of SES has been education. So all of the data, when I show it with these race ethnic disparities, often will have education already controlled for. And you're right, many of the social determinants of health, education, access to, even places where one can be physically active in parks, the food deserts that we talk about, we're beginning to measure with new social determinants of health. They definitely have an impact. For now, we do try to control for that. In the Florida Stroke Registry, we have added in education, and in our newest data, because we have zip code, we can bring in some of the other local social determinants of health, including, median income in a region, access to other resources in a region. But SES and social determinants of health are huge drivers for many of the social disparities. For now, like I said, I think even when you control for a lot of them, you can show a diminishing in the disparities, but not a total elimination until we can get the risk factors also controlled. There's obviously a lot of confounding, and there's a lot of connection between those social disparities, those social determinants of health, and the disparities, without a doubt. So the AHA and some of its guidelines has focused on policy implications that will hopefully, try to eliminate some of the social determinant of health disparities that are out there. Important question.
Hi, Dr. Sacco.
Yes.
Hi, my name is Susan Law, and I enjoy your talk very much. I have a question regarding disparities in patients who have stroke centers who only have access to primary and not thrombectomy. Has there been any type of evaluation of door in, door out times for these types of patients?
So it's a great question. I think when you say door in, door out, you're talking about transfer protocols?
Yes.
Yes, we have looked at that. And as you know, there are even some clinical trials now that have talked about direct to comprehensive versus go to your local primary and then be transported. And we do find that, first of all of our primary stroke center metrics are better in the comprehensive compared to the primary stroke centers. Comprehensive stroke centers obviously have more infrastructure and resources and support to do everything with evidence-based approaches, and they perform better. We haven't looked at specific transport yet and whether there are differences, but I think particularly for EVT utilization in Florida, because of the concentration of our comprehensive stroke centers, often EMS is making the decision in the field that if they have an LVO and they're close to, and most of the time they can get to a comprehensive stroke center and they're EVT eligible, that they're going to directly take them to a comprehensive stroke center. If anything, everybody is wanting to be a comprehensive stroke center now, or a thrombectomy capable stroke center. We recognize that sometimes when resources are scarce, that's probably not the most efficient thing to do. But in the competitive world that we live in, many of the hospitals do want to be all comprehensive stroke centers. I think what we haven't looked at is a good one. I think you're talking about even whether there are disparities in those transfer, and we have not looked at that yet, recognizing that there are some delays that occur even in those cases that come to primary stroke centers and don't go to a comprehensive stroke center immediately. In Florida, a lot go directly to the comprehensive stroke centers right now that are LVO capable. But I will bring that back to the team, and we'll look at it across the race ethnic groups to see if there are transfer differences, because that would be important. And that would be another area perhaps of educational intervention. Thank you for that question.
Yes, hi, Dr. Sacco, and thank you again. Congratulations for the nice talk. This is Nick Pamitsakis. I have a question regarding the follow-up of patients, because sometimes many times we encounter this problem that patients don't follow properly with a stroke clinic. Obviously, if you are in a trial, you have the mechanisms to ensure that people do follow up, either in the NOMAS or the other trials in Florida. What would be your recommendation for, let's say, a primary stroke center or just general practice to ensure that patients follow up appropriately and, we manage the risk factors well?
Yeah, I think that's the critical question, because I think you're right. We do everything so well in our acute stroke centers, and then we get them all packaged and they go off to the community and things fall through the cracks. I think one, it's not just the patient, it's also sometimes the systems, the way. Do we have good handoffs when we package them to go home to their community docs? Do we have a telephone follow-up that we should maybe do at all of our primary and comprehensive stroke centers? Are there ways to engage community health workers to say, hey, go follow up with this person in the community, particularly if they're in a culturally less accessible community? We need to find better ways, I think, to connect these stroke, what I call victors. Our stroke caregivers and survivors said they don't want to be called stroke survivors. They're stroke victors. They got through their first stroke and they want to make sure that they're connected and doing everything they can to reduce that big fear of a recurrent stroke. Some of it's individual, obviously, but then we have to make sure that the healthcare system is doing everything it can to make sure that individual is adherent and has access to all the right resources to reduce the chance of a recurrent stroke. We're not there yet. And transitions of care, and there have been some programs. Pam Duncan has created this large program in North Carolina where she had all of these nurses in the whole state trying to follow up people, and it still wasn't able to show a significant difference. So we are not there yet. We are trying with our transitions of care study first to identify who is at risk for a poor transition of care. Those that may live alone, those that may not have someone that will help them get to the doctor, those that may not have a primary care doctor. What are the factors that identify a poor transition of care? And then, given those factors, what do we need to do to improve it? And obviously, it's going to take more resources. Do our primary stroke centers need to have a follow-up coordinator that's paid for by the hospital that then will help improve the care for those that are leaving? Because you're right, they may not come back when given that appointment, and we may need other ways to improve that adherence, reminder calls, systems now that can be done with their phone even to remind them and connect them in. Centralized systems that maybe the state may need to take on and say, we're going to then call every stroke discharge and make sure they do A, B, and C. I think we do need a lot more to reduce and improve that transition of care.
Thank you very much.
Great lecture, Dr. Sacco. It's Tony Wong. Quick question. Do we know the percentage of patients in Florida that could have direct access to the comprehensive stroke center, but actually end up in a primary first for either lack of knowledge from the patient or EMS triaging system? We know, as we know, the comprehensive centers have a better outcome than the primary, and transfer often involves delays. Do you have the data or percentage that those patient population?
I don't have an exact answer, but what I can tell you is that as part of our Coverdale application, there is a new protocol, a phone-based protocol that when 911 calls, they're trying to do and train the operators and the EMS people in the field to identify LVOs even better through this. Our EMS director has, I forget the name of it, but it's a protocol on the phone to improve recognition of an LVO. And then if you recognize that LVO and they've activated 911, that you'd be taking to the closest comprehensive stroke center. In Florida right now, using a variety of the LVO techniques, they do usually transport you to a comprehensive stroke center. If you don't call 911, obviously that's a different issue. And those that come in on their own may go to the wrong stroke center. But if you do activate 911 and an LVO is potentially recognized within the time frame, the majority of our EMS personnel, particularly in our regions now, where the EMS people are very connected with the stroke centers, they will go directly to comprehensive stroke centers. But I still think we have to dissect the data a little bit more when we get better EMS data to see where things may be falling through the cracks regarding transport policies, because we can do more to get them to the right center when they are eligible for EVT. In the Panhandle and that area up at the northern part of Florida where there are great disparities, there aren't enough comprehensive stroke centers there. And so that's a place where we're trying to do, if anything, to improve and maybe help the primary stroke centers possibly regionalize care a little better there, to have more comprehensive stroke centers available, particularly in the African-American population that lives in the Panhandle. So there are some places that are more resource poor when it comes to comprehensive stroke centers, and we need to get the policies out there to improve access to comprehensive stroke centers.
Follow-up question. Thank you so much. That's great. Do you guys fly patients, helicopters, anything, or because it's a large state and you don't have flight restrictions? That's New York City.
Yes, that's true. Yes, we do. Actually, we have for anybody who's going down to the Keys, it's called Monroe County. There is no comprehensive stroke center in Monroe County. So we have EMS direct calls to us at Jackson in Miami, where we can get from the field a comprehensive stroke patient directly brought in via helicopter to our comprehensive stroke center. In other parts, even in West Central Florida, there are individual, remember these are very healthcare system specific, because these ambulances are really owned by a healthcare system as opposed to like a state-based or one. Our county hospital has one and our private hospital has one that can be utilized. The next question obviously are mobile stroke units, which are beginning to pop up. And I know they're existing in New York and other places. We don't have any in Miami-Dade County, given the current density of primary and comprehensive stroke centers, but there is one or two, the Cleveland Clinic runs and others in Palm Beach County. But that may be another way to improve in the field access, at least to TPA. But you're right, particularly in a large state like that, in more rural or areas where there aren't comprehensive stroke centers, you know, having the capability to bring people in by helicopter makes a big difference.
Thank you.
Okay, if there are no more questions, I would like to thank Dr. Sacco again. Thank you very much for taking the time to give us this great lecture. And I guess the discussion was also very nice and productive. I would like to wish everyone a good weekend. Thank you very much for joining us today.
Thank you. Thank you for having me. Hope to see you in person next time.
Likewise. Thank you very much, sir.